to having Dr. Ali Badra and Dr. Ala Ahmed as our panelists. So I'm sure that this webinar will be very interesting to all of us. I leave the mic now to the panelists to start the session. Dr. Ala, please.
Yes, this is Dr. Ala Ahmed. I am Associate Consultant of Vascular Surgery. Firstly, I would like to welcome all our respected speakers. I think we will have a wonderful speaker from all over the world with accredited CME hours for the registered audience. So we will start the first session with Professor Krzysztof Sosanowski from Poland. He is the head department of the vascular surgery in District Hospital number 5 of Roma Center. Dr. Krzysztof, you have the mic now.
Good evening or good afternoon, everyone. I will share my screen to start my presentation. So good afternoon or good evening to everyone. My name is Krzysztof Sosanowski. I'm a head of the Department of Vascular Surgery in Sosnowiec, south of Poland, and I would like to present a presentation about basics and fundamentals of below-the-knee interventions. I will try to say some important words about anatomy and about the disease itself. However, I also have a few cases to show. So in general, considering the below-the-knee interventions, we have to remember about the risk factors we have. The most important are age, where disease is located mostly distally. Male gender also predispose patients to have lesions more distally than in female. And also diabetes mellitus is one of the risk factors which are responsible for below-the-knee disease. In general, in Poland, mostly the patients who are admitted to hospital with below-the-knee issues have critical limb ischemia with some tissue loss, and the amputation rate is high in that group of patients. So everything what can be done below the knee, of course, if above the knee situation is also solved, well, somehow protect them against the amputation. So some anatomical basics. This is the typical angio of calf with anterior tibial artery and posterior tibial artery, and not very wide peroneal artery. And this is a typical situation. In next few slides, I will show the anatomical changes in that region. On the foot, we have, of course, two anterior tibial and posterior tibial, and also medial plantar and the arc. What is very important, we can see here on these two slides very many reconnections between the arteries. This is a very important thing. It is also used with angiosome theory. However, these interconnections are, for me, very important in revascularization, especially when we are dealing with the tissue loss. As you see here, also all these reconnections looking like perforating veins between the deep and superficial venous system in the veins. It is quite the same situation. I mean, all these arteries are communicating each other, and more distally we go, more communicators we can see. Now, if you look at the anatomical types, we have 6 anatomical types of 5-6 anatomical types of the angiographic anatomy. For example, B when you look at the type 1B, you can see it's not a very common situation that we have trifurcation and 3 tibial arteries. The most typical, I think, is A and C, but we have also sometimes, for example, hypoplastic arteries, like hypoplastic artery in the picture E or in the picture D. That sometimes can be misinterpreted that, oh, we have occlusion here, but it is hypoplasia, not occlusion. So what we should do dealing with the patients with below the knee arteriosclerotic lesions? Usually there are not single ones. I mean, usually there are 3-4 lesions to treat. So the first question is to address, shall we treat all pathologies or only patients with critical ischemia? Because in our department, mostly we have diabetic patients with critical ischemia. Sometimes we are asked by diabetologists, they make angioscans and asking us whether we treat these patients. In my opinion, if the patient has only not nice looking CT, but he have a good walking distance, we usually do not treat such patients. The second question is all vessels at once or one by one in 3, 4, 5 procedures. It is also very important. And outcomes of the therapy. In very many cases, I'm very happy. I make a very nice procedure. I have a very nice angio, and then there's no effect. There's no wound healing, and we end up with amputation. Or different thing. We have a very bad angio. It doesn't look nice, but patients feel better, and after a few weeks, he go to us, and he's got the wound healed. For example, Dr. Aladdin and me, I don't know, maybe 2 weeks ago, had such a procedure that we didn't succeed. However, patient was well and went home with no symptoms. The angiosome theory. The angiosome theory, it's a kind of different approach to the problem of the below the knee. The most important thing is that distally, Taylor and Palmer described 6 angiosomes, which means areas which are fed by one feeding vessel. And what is important? This multiple connection between below the knee arteries, which can be used or as parallel blood source to the angiosome. It's a popular concept, however, it is discussive. I mean, there are strong supporters of the angiosome theory, and there are also strong enemies of the angiosome theory. This is a typical case of occlusion of both tibial arteries, and the foot is fed only by peroneal arteries, but because of these interconnections, we can reduce the risk of the amputation. If we, for example, have a lesion at the peroneal and we can get rid of it or make a PTA and improve the inflow to the one vessel by these interconnections, we can improve the influx of the blood into the foot. So the question is classical perfusion good for patient or angiosome concept is good for patient? In my opinion, there is no conflict between these two theories. The most important thing is inflow of the oxygenated blood to the foot. So it doesn't matter how we can achieve this effect. We can achieve it endovascularly by making procedures like PTA, atherectomy, improving the flow, or stenting sometimes. We can also make distal bypasses to improve flow, or we can mix these procedures. It's up to us. In my opinion, if the obstacle is more proximally, the classic theory works. For example, if we have a femoral problem and we improve the flow, sometimes we don't have to treat below the knee intervention. We don't need to make a below the knee intervention. Or for example, in popliteal artery, or for example, in tibioperoneal trunk, and we have multiple lesions down. If we have disseminated lesions at distal part, like maybe distal half of the calf, in that case, the angiosome theory seems to be more efficient, I think. So what are the concepts of intervention? My concepts, I mean, every one of us has favorite instruments to use. In my opinion, the preferred diameters of the wires are, for me, 0.0014. However, 0018 is also a good wire for below the knee intervention. Sometimes 0035 also works. However, it is a bit too thick for me. If I have stenosis, my favorite wire is Barton Rider. It's very delicate, easy to destroy. However, it goes with the flow, so it's quite easy to catheterize stenosis. In chronic total occlusion, I use Victory from Boston with shapeable tip, good support, and you can choose the tip loads. In my opinion, it usually depends on the lesion length and of the calcification. More calcified the lesion, I use more G's in tip load. The second thing is access. We can have, of course, classic access from the groin, and here we can choose or to use traditional sheaths like 11 millimeters, or use a long sheath, for example, 45, to put it to the popliteal artery to have a good support if we need to pass a long occlusion, for example, below the knee. Of course, support catheters. My favorite is Merit, just diagnostic catheters for French, which is easy to use with the valve, or vertebral from Barton. We can use balloon catheters, for example. I mean, you go with a dedicated balloon and having support with the wire of the balloon. Of course, there are dedicated catheters like Seeker and Navicross. Navicross is good because you can make a telescope method and use both of it. I mean, 0045, 0035, and then inside of it you can use 0018. So sometimes it's a good solution, but of course it costs money. So this dedicated stuff is expensive. Another concept, atherectomy. In my practice, I use Hook 1. I have used Hook 1 rather proximally on the calf, below the knee, however, proximally. Only S-type can be used. I would say that effects are 50-50. In 50% of cases, I had a really nice angio and really nice outcome. In another 50% of cases was so-so. However, there was no any kind of catastrophe with using Hook, but you have to remember that the distal embolization can occur. So the producer also advised to use the neuroprotection or protection devices like whatever, Spider or Robin, whatever protection device you use, 0014. It is better because sometimes you have to deal with embolization of the foot. Shall we make a stent implantation? In my opinion, it is only when you have to. The only stent I could implant into below the knee was woven stent from Jaguar. It's soft, maybe, and it has good conformability. I mean, for example, you can put it to the tibial artery and ending up with into tibioperoneal trunk, and in general, it would act like as tapered stent. So now a few cases. This is the first case. Of course, patient with rest pain and 2 toe necrosis. Typical comorbidities. Occlusions. There is no ATA. The TPA is occluded just in 1/3, and there is a stenosis of peronella, and this is the only feeder of the foot. So we used Merit as a support catheter 0014 wire, and we made a low pressure balloon angioplasty. Then we made we passed the occlusion of the PTA posterior tibial artery with the Victory 0014, and then some remodeling, and well, the outcome was good. We didn't. Sorry. This is the final angio. After 30 days, we had to make some surgical therapy of the necrosis. However, the patient was well and necrosis healed. This is the second patient, also after amputation of the toe, no healing, and necrosis of the first finger of the foot. As you see, critical stenosis of the tibioperoneal trunk, and stenosis here, it's about 50, maybe 60%. Of course, after active smoker. Both of the patients were active smokers. This is the similar situation. I used Merit vertebral for French catheter as a support, Victory wire to both vessels, and slow low pressure. I mean, starting from 2 atmospheres going to 4 to have a pop-up with the Ludwig's balloon, and then Impag Admiral drug-eluting balloon to both vessels, also with a good effect out after a month. And of course, the patient still smokes. So he'll be back soon, I think. This is an example of chronic total occlusion with severe claudication, about 30 meters, also active smoker with coronary disease. This case, we saw it with Terumo wire 0035. Here you can see the catheter. This is a typical vertebral catheter. And after that, predilation with typical PTA Ludwig's balloon, and treatment with drug-eluting balloon. In that case, it was PAC. After 30 days, walking distance improved to 100 meters. Of course, the patient is still smoking. The angio doesn't look very nice. You can see a big calcification here, some remnants here. However, well, the clinical effect is okay. So by now, we are not making any additional procedures in the patient. This is the case number 4. It's not clearly visible, but here between X2 and X3, there is an occlusion because there is a line drawn during the measurement. And also we have critical stenosis here. Of course, severe claudication. This lady had also history of PTA, angioplasty of popliteal artery in 215 and right tibioperoneal trunk in 216, and was admitted again with such angio. And also, this is the final effect. We had a dissection here in the central part of just before. Of course, this occlusion was reopened, and also this critical stenosis was fixed, the problem. However, here we had a dissection, and the question is, to put the stent here or just to leave it. We decided to leave it, and well, she was okay after 30 days. This is our typical time of control of the patients. The walking distance improved, so we left it. We left this dissection without any kind of additional stenting or whatever, but only way is stenting here. This is the case of the patient with also tissue necrosis. I mean, the foot ulceration with the edema of the left foot. This is, of course, typical diseases, concomitant diseases, and also the history of left tibioperoneal trunk, PTA, a few years later. First, we catheterized the ATA with Victory 0014 and made an angioplasty. And then we tried to reopen this, I'm sorry, to reopen that artery, this occlusion, the posterior tibial. However, we didn't succeed. I mean, we succeed with the lesion crossing, we succeed with PTA, with the long balloon. However, the final angio didn't look good. I mean, there was no flow, thrombosis maybe, I don't know. We decided to leave it because we also treated the second vessel. This is the effect. As you see, maybe we partially reopened it because I think that it started here, now it's a little bit better. However, these interconnections occurred. So the flow was improved, we left it. And as far as I know, after 30 days, I didn't write it here, but the patient is well and there's no problem with the wound healing. But it was not it was, I don't know, maybe 2 months ago. So we are still having him as in outpatient clinics. However, the wound healing or ulceration healing is okay. And this is also a patient with fat ulceration with the edema, with the coronary disease, and also a history of tibioperoneal trunk. This is the last case. Tibioperoneal trunk. As we see, there is a short occlusion of the tibioperoneal trunk at the trifurcation. Here, maybe it's endpoint of popliteal artery. However, here you can see occlusion. We decided to cross it with Victory wire, somehow heavy, 25 grams. It was successful. After that, we made some PTA with the balloon. I've written here it's 440. And this is the final angio. We didn't decide or haven't decided to put the stent in here because you can see the flow is not like there is a shadow, a sort of shadow here. The angio isn't nice. However, we left it and the patient is also well. Well, now a few words about possible complications in below the knee therapy. First, extravasation. Usually it's insignificant. Sometimes we can observe hematoma if there's active flow.
Dr. Christoph, I'm sorry to interrupt, but can you finish? Yes, if you can finish within 1 minute, it would be nice.
It is one slide, so I will finish in 1 minute. Our worst enemy is distal embolization, in my opinion. If something will will embolize the distal parts, this is some kind of problem. Of course, we have, like on this slide, some methods to deal with it. However, this is for me most the biggest issue in complications. And supportive stenting, if we have dissection, only if we have to. It is my opinion. So that was the last slide. Thank you very much, Professor Mahmoud Salah, for inviting me. If you have questions, of course, I'm happy to answer. So please.
Thank you. Thank you very much, Dr. Christophe. And I guess we'll keep the questions to the end of the session. Dr. Ala.
Okay. And let me introduce Dr. Ahmed Effendi, the consultant of general and vascular surgery in King Fahd Armed Forces Hospital in Jeddah, Kingdom of Saudi Arabia. And he will talk about the patient's factors affecting the BTK revascularization. The mic is yours, Dr. Ahmed Effendi.
Yeah, hi, good evening, everyone. It's evening here in Jeddah, Saudi Arabia, and I hope you enjoy your time everywhere. Thank you, Dr. Mahmoud Salah and the scientific panel to give me the chance to speak to you today about the presentation. Just I'm wondering if the view is okay with you guys.
It's good.
So my speak today will be mainly about the patient's factor that affecting the success of balloon angioplasty, and the rationale. I will summarize the rationale behind many of the therapeutic decisions that I'm making for my patient, and how aggressive I will be depending on the risk factor that they have in the treatment or in the follow-up. So regardless what evidence-based principle and guidelines you are following, regardless it is American Heart Association or European Vascular Society or task classification, all of them, they share a lot of things regarding the treatment of peripheral arterial disease. So be familiar with the one suits most your population. Here, I will show to you some of the basic of the risk factors. I thank you for the previous presenter who also mentioned the risk factors. So most important risk factor is age and advancing in age, diabetes, smoking, hyperlipidemia, with or without obesity, obesity itself, hypertension, chronic kidney disease. Also, I would like to mention later on about the race as a risk factor and existing atherosclerosis. The risk of peripheral arterial disease increased substantially. 1 minute, please. I can't see my, sorry for that. The risk of it seems that I have a problem with my laptop. Minute, please.
We can see your slides, Dr.
Yeah, but I cannot move the slides from here. Do you know?
Dr. Ahmed, we would suggest you to just stop sharing and then start sharing again.
Okay.
We can see your slides now.
Okay. Sorry for that. The risk for peripheral arterial disease increased substantially with age, and more than 50% of patients are asymptomatic. Also, Peripheral arterial disease is associated with twofold increase in prevalence of heart failure, which also will affect your decision making when you came to the treatment. As well as we know in many population, 30% of population became now diabetic, and these will increase 4 times the risk of peripheral arterial disease. Smoking also is another problem. It associated with 3 times increasing the risk of developing the peripheral arterial disease, as atherosclerosis is one of the major risk factors and account for 90% of the disease. And usually if it happens, femoral artery, popliteal artery affected 90%, and the prevalence of the amputation will be about 4%. Here is an example of our routine case who is a 65 years old female, non-hypertensive and diabetic and smoker with absent pedal pulse and uncontrolled risk factors. In this slide, I will just briefly explain to you that if we are studying the risk factor and the association with each risk factor to the developing of peripheral arterial disease, we found that diabetes has a relative risk factor of 4.1, active smoking relative risk factor of 2.5, hypertension is 1.5, and high cholesterol level more than 10 milligram per deciliter with relative risk factor of 1.1. And in these slides, we can see how can risk factor when be conjoined in one patient, how can they act in additive way. So that can explain the severity of the disease with increase only one risk factor add to another risk factor. Now I will speak about revascularization of the lower limb and advancing in age. It is interesting to see this prospective observational cohort study where 195 patients were included and divided into 3 treatment subgroups, which were treated by endovascular, surgical, or just conservative treatment. They found after 2 years, the physical quality of life had significantly higher score more than the baseline measurement of all treatment group. Endovascular were the superior, about 14% versus 11 and 9% for other modality of treatment. As a conclusion for elderly patients with peripheral arterial disease, we concluded that advanced age is considered relative contraindication for surgical revascularization in frail geriatric patient, and individual tailored revascularization improve the outcome of critical lower limb ischemia in elderly. And endovascular revascularization should be performed because of the higher mortality associated with the surgery. And for patient aged between 65 to 74 years, diabetes increase the risk of amputation more than 20-fold, putting these patients at greater risk of limb loss. Revascularization in patients with diabetes. First, we have to remember that many studies have shown similar peri and post-operative mortality in patients with diabetes compared with non-diabetic, but diabetic patients had a higher risk of incompletely wound healing, major amputation, prolonged hospital stay, and frequent readmission. As the fact all of the patient increase, all of the diabetic patient increase the risk of peripheral atherosclerosis and critical limb ischemia. Also, diabetes associated with greater prevalence of lower below knee arterial disease, as well as the disease when involved this artery, it will act in multi-segmental fashion with impaired collaterals. Now, how the question will be a surgical or endovascular revascularization. Okay, There are different opinions of revascularization depending on several factors, including anatomical location, extension, and length of the arterial lesion, plus the general health condition of each patient and the comorbidity the patient has, as well as the center and the surgeon experience. While surgical revascularization provide good long-term patency, also with longer hospital stay and increased risk of perioperative and complication and mortality when compared to endovascular procedure. But with the development of new technique during the last decade, the importance of endovascular therapy became more popular. And that supported by many guidelines from different society recommending to have endovascular therapy as first line for infrapopliteal arterial disease treatment and for short lesion. And also it can be tried for longer lesion if the surgery considered to be high risk or in absence of autologous vein. Revascularization in patients who are smoking is a bit problematic, especially for me. Anyway, as we know, smoking is a major risk factor, and claudicant patients who smoke progress to critical limb ischemia at rate of 3% annually, with double the risk of amputation versus non-smoker. Also, smoking has been shown to be independent predictor of failure of treatment of patients with peripheral arterial disease, and the cumulative restenosis rate at 6 and 12 months in one study were up to 51%. So I advise everyone who has a smoking patient to have a very aggressive follow-up with them.
Dr. Ahmed, I'm sorry for interruption again, but the time, please.
Okay. So I will be faster here, and I will speak quickly about the gender. We know that nowadays we are seeing more female patients coming to our clinic with peripheral arterial disease, and we have to remember that these patients tend to have more complication and complex lesion than male patient, but they have a very nice thing. They have a free amputation-free survival rate more than male patient. One of the problems that noticed about female patient is that they're adherent to the treatment before the procedure as by guidelines. Also, COPD, patient with the COPD, they have in one study they found they have a higher mortality rate if revascularized. And finally, the end-stage renal disease and the action on the peripheral arterial disease, especially the below knee, they have the worst prognosis because of the lesion itself, and the posterior tibial artery involved mainly with a very low revascularization rate. These slides will show to you some of the classification and to indicate that the below ankle arch indicated the failure of the revascularization if not revascularized. Finally, about the race, I can share here with you the study which was published, and it indicated that the race, it acts as independent variable factor that can affect the amputation rate for patients with peripheral vascular disease. Black gender, they have the higher rate of amputation regardless other risk factors. That was my last slide, and I would like to thank you all.
Thank you very much, Dr. Ahmed. And let's move to the next speaker, Dr. Ahmed Sakr, my colleague. He's Associate Consultant of Vascular Surgeon, Saudi German Hospital, and he will talk in his presentation about single versus multiple vessel revascularization series. Dr. Ahmed, let's start, please.
Good evening, everybody, and thank you very much for this opportunity to join you today I'm going to talk about single versus multivisible revascularization theory in critical limb ischemia. Okay, I have no disclosures. So in every critical limb ischemia case, I'm always asking myself, is one straight line is enough for wound healing? What is necessary and sufficient, single or multivisible revascularization? And what about the ankle area, still foggy area? So in my opinion, it's a demand-supply ratio, what wound needs and what we can offer. The below the knee area is different from any other areas. It has multiple vessel disease, and it is not usually a single disease. It is combined multi-level disease. So when putting the strategies for revascularization, we have two questions. First of all, multiple or single vessel revascularization. And if we choose to go for single tibial vessel revascularization, do we have to follow the target artery path, the wound-related arteries, the angiosomal guided, and which is the best? And in the review,
the slides are not moving.
The slides are not moving, Dr. Ahmed. Enlarge your slide, and then because we're still seeing only the first slide.
It's moving here. It's moving in front of me. Can stop share. Okay, share again.
Click presentation way. Hi, Ahmed.
Hi, Dr. Marco. It's not moving still?
Yeah, it's moving now.
Okay, so I'll go from here again. So in every critical limb ischemia case, I also ask myself, is it one straight line is enough, necessary and sufficient, and what about the below the ankle area? So in my opinion, it's a demand-supply ratio, what wound needs and with what we can offer to the wound. And especially in the below the knee area, it's a multivessel disease, and it's not usually the single vessel disease. It's a combined multi-level disease. So putting the strategy for revascularization, I have two issues. Do I have to go for multiple or single tibial vessel revascularization? And if I have to choose one of them to single vessel, which one? The target artery path, wound-related artery, or angiosomal guided? And in the review of literature, we have a bunch of studies published already supporting each of the theories. So let's start with the multivisible tibial intervention. What is the point? Can it improve the chronic limb threatening ischemia outcome? Multivisible dilatation increases the foot perfusion, and this is of course fastening the wound healing and increasing the patency. But does it really increase the critical limb ischemia salvage rate? This study was published in 2010, showing the angioplasty of infrapopliteal arteries, long-term clinical follow-up, and analysis of the factors influencing the clinical outcome, showing that one vessel is better than 0, and 2 and 3 vessels is better than 1, and this is after 1 year. So what is with this theory of multivessel revascularization and what is against? The tibial patency rate, as we know all, that it's poor patency, as low as 30 to 50% primary patency in 12 months in some studies. So the higher rate of patent vessels suggests that better tolerance when losing patency in one of the feeding vessels. But in contrary, if we are going to use the multivessel revascularization, we are increasing the cost, we are increasing the radiation exposure, and also increasing the contrast volume. So going back to the same slide, does it really increase the limb salvage rate? We have to go the review of literature, and let's start with this study published in 2014, effect of single tibial artery vascularization on microcirculation, and the conclusion was revascularization in one of the feeding vessels, giving the same effect in microcirculation of the foot. Second, about the type of the disease in single vessel below the knee, and it shows that patient with isolated tibial intervention having poor outcome. Third was published in 2016. Number of infrapopliteal artery undergoing endovascular treatment is not associated with limb salvage rate in patients with critical limb ischemia, and it concludes that only one amenable artery can improve the foot salvage. And of course, when we go to the Vascular Quality Initiative published in 2019 that concluded that the patient with critical limb ischemia and below the knee multivisible disease didn't have any benefit from, according to the limb salvage from multivisible revascularization. But especially the vascular quality initiative, we have to go deeper in this study. It was collecting data from 2002 to 2017 that included 10,849 patients, but the correct data was only for 761, which is 7% only. And they concluded that single vessel tibial intervention group was statistically more likely to have multi-level intervention with concomitant femoropopliteal intervention than those with multi-vessel intervention. And the key was having inline flow to the wound area, but more doesn't seem to be better. What is the limitation of this quality initiative study? That a lot of lost data in the follow-up. They started with thousands of patients and they ended with 761 only. Limited long-term follow-up wasn't available, and no information about the wound location and care, and no data about the pedal arch status. So this takes us to the second question. If I choose to go for single, as a theorist suggesting that to go for single artery, which artery? The target artery, bus, wound-related artery, and angiosomal guided, is it enough or no? This is, of course, the angiosomal territory. And we have also a lot of studies that supporting direct versus indirect revascularization published in 2014, 17, and 18. But in clinical life, each day in our clinics, and for all of you, my colleagues, seeing different category like this of cases. And we have to choose what to do and what strategy we have to deal with. Of course, most of lesions having more than angiosomal affected, but sometimes we have single area with gangrenous part, like we can see in those pictures. So if we are looking to the angiographic pictures, we can see also different pattern of loss of the pedal arch, of loss of the posterior tibial artery or anterior tibial artery according to the lesion area. So if we have a direct angiogram, we have less disease in the posterior and the tibioperoneal artery, and we have a total occlusion of the anterior tibial artery. Still, we are fighting to get the anterior tibial artery and to have the pedal plantar loop to have perfect perfusion to the foot. Although here in the same idea, if you have a posterior tibial artery and you have a good anterior tibial artery, you're still fighting for the posterior tibial artery to have a good inline flow to the wound area. The same idea, anterior tibial artery is having good flow but without pedal arch, and the posterior tibial artery is occluded, so we are fighting still to get the posterior tibial artery and perfusion to the calcaneal area and the wound related area. And we don't know still, it is a theory or fact. We are defending a theory or fact. So talking about direct revascularization, as we said before, it have multiple angiosomal territory, and majority of them, 47%, having more than 2 angiosomes. And the conclusions is the tissue lesion affected several angiosomes in majority of cases. So direct revascularization appears to result in improving wound healing and limb salvage rate compared to indirect revascularization. Why direct revascularization? Because it's giving better wound healing, shorter time to wound heal, great limb salvage rate, and no effect on mortality or reintervention. But the limitation against direct revascularization, as we are ignoring the collateral circulation status. So if we have indirect revascularization with good collateral, it is much different from poor collaterals with indirect revascularization. And some of the indirect revascularization patients have been failed direct revascularization, and this gives us a feedback about the severity of the disease. So if we are going to put a perfect question to ask us ourselves before any intervention, that was mentioned in the Global Society guidelines for chronic limb ischemia, what is the comparative value of direct angiosomal based versus indirect revascularization in setting of tissue loss, and should it drive selection to preferred target artery path? Is this specific to wound location or Wi-Fi classification? And this takes us to the recommendations of the Global Society of guidelines that recommended that restoring durable pulsatile inline flow to the affected part, particularly in patients with tissue loss, is a primary goal of revascularization in critical limb ischemia. And they mentioned also that The current version of GLASS doesn't consider multivisible revascularization because evidence is still lacking in this area. This is the last, as we mentioned, always against direct versus indirect revascularization. This is the last published study this year, 2021, and it concludes in Belgium, and it concludes that the retrospective study with comparable result for direct and indirect revascularization didn't show any difference in achievement of the wound healing goal. So in conclusion, the multi-vessel revascularization doesn't have strong proven support over single vessel theory. Recent study guidelines summarize that angiosomal guided revascularization may be of importance in endovascular intervention with significant ulcer healing in case of direct revascularization. Before any intervention, we have to look to the wound, evaluate the target artery pathway, and if we have a multiple vessel disease or no, and what is the status of pedal arch. In patients with a small minimally infected wound, a single target artery path is sufficient provided optimal balloon angioplasty is achieved with a linear pulsatile flow to the affected tissue, and to know that most of wounds having a multiple angiosomal feeding vessels and having direct artery is preferred if feasible. Thank you.
Thank you very much, Dr. Ahmed Sakr, for the nice presentation. And we will move to the next presentation, which is presented by Professor Marco Manzi, the consultant of interventional radiologist and the director of the vascular intervention unit in the polyclinic. So Marco.
Before Dr. Marco starts, I would like to introduce him as and he's a very dear friend, and we had a lot of communication and cooperation. He's visiting us in, actually he was before the COVID. Yes. He was visiting us in Saudi German hospital, and all of my team actually went to Abano Terme in Italy. And thank you very much, Marco, for being with us today. The mic is yours.
Thank you, Mahmoud, dear friend, and thank you for the invitation. It's an honor and always a pleasure to join you and to share with you all our experience. It's really a good pleasure to see you all after all these years. So we still are fighting against the same diseases with the same passion, and that's a great hope for our patients. So thank you again. My topic for today is different strategies to crossing BTK lesion. This is my disclosure, and I would start my presentation with this slide showing our everyday strategy when we perform procedures. So we published this strategy with this name, this step-by-step crossing strategy, which is meaning that we always perform the procedure with an integrated approach, starting first with an endoluminal approach. If we fail with the endoluminal approach, we try to shift to a subintimal approach. And when we fail with a subintimal approach, we start to consider a retrograde approach with or without puncture. So we can consider to follow the communication, the anatomical communication as the pedal plantar loop technique or transcollateral, transperforant, or we can decide to perform a retrograde percutaneous puncture in the distal patent vessel or in an occluded vessel in the distality. So probably, despite all these technical tricks and the combination of all these technical tricks, of course, the calcium remains the main failure cause, together with the presence of small artery disease. So when we have patient I saw the slide of our colleagues speaking about the renal foot, so the end stage aspect of the foot. So when we have a complete failure of the distribution of the blood flow in the forefoot or in the rear foot. So practically, I would like to share with you three cases. You can see here an antegrade approach. This is a CO2 angio performed with the automatic injection. This is a patient with a non-healing transmetatarsal amputation. You can see here that there are the flow seems to be quite acceptable, but there is a fistula, probably an arteriovenous fistula due to the intervention. The flow in the forefoot in this amputated foot seems to be good, but there are no, in the reality, there are no direct vessel arriving into the foot. So this is the aggressive subintimal revascularization of the anterior tibial artery performed with the 4 French Bernstein catheter type 2, together with the Terumo Advantage 1/8 wire. You can see the possibility to maintain the loop of the wire quite narrow in order to avoid any damage on the vessel. It was possible to land somewhere into the dorsum of the foot. So now problem is find out the enter and we do with the 1/4 wire, and we use the tip of the 1/4 wire. You can see here that the wire seems to be capable to follow the anatomy, and in effect you can see here that there is an outflow, there is the possibility to arrive in a patent arch still existing after the amputation, of course, but we could not appreciate this anatomical aspect with the initial angiographic examination. You can see here the micro catheter. This is a micro catheter guy distributed by Biotronic, and checking the anatomical position, we finally can be sure to be in the real true lumen of the arch. There is also a lateral plantar artery patent in this foot, so we can decide to delay after this recanalization aggressively this anterior tibial artery and the pedal artery, in order to have a direct inflow and outflow towards the amputation. You can see here the aspect with CO2, and we see the perfusion of the forefoot completely different compared to the initial aspect. You can see here the blushing effect into the forefoot. This is the perfusion angio after the procedures, demonstrating the angiographic successful procedure. So in this case, despite the aspect of the posterior and lateral plantar was quite good for the plantar side of the foot, the amputation was opened because no vessel in the dorsum of the foot. So the idea to recanalize the anterior, the pedal, and the arch was the winning idea. This is another case of non-healing transmetatarsal amputation. Again, the difference is in the amount of calcium. Again, CO2 angiography, antegrade approach, 6 French short sheet. You can see here the velocity, the speed of the inflow is not so high because of the high resistance in the distality. The vessel seems to be open, but in this case, we have a severe calcium amount, and the disease is mainly below the ankle. So the problem is from the ankle in the foot. You can see the amount of calcium is really tough. Especially when we arrive in the malleolar area, the amount and the color of the calcium is really severe. The anatomy is quite tortuous. So again, we are using a wire capable to navigate in the middle of calcium. And this is a Fielder FC wire from Asahi. We could successfully cross with the wire, but you can see the single marker high, low profile balloon could not pass through the subocclusive stenosis in that common plantar artery. You can see here the aspect of the disease. So in this case, when we have the wire through, could be useful to be really aggressive and using the strategy of the piercing technique. You can see with the 18 gauge needle, we perform the puncture, the direct puncture of the artery transcutaneously, and we try to crack completely the calcium and the lesion. We try to destroy the artery in this way, but in most of the cases, this is could be one possible solution, but really efficient in let the balloon advance into the occlusion or tight stenosis when we have this kind of calcification. In fact, you can see after several punctures, we have to be really aggressive when we do this. Of course, I have to remember that you can see here the balloon could pass, could be inflated, and could successfully dilate the lesion and arriving up to the lateral plantar artery. You can see here the high pressure, non-compliant long balloon to perform the definitive dilatation of the artery. And this is the aspect of the artery after the final control. You can see here the attempt to recanalize even the dorsalis pedis. So we had a short occlusion of the dorsalis pedis. So we try to complete the outflow into the non-healing amputation. Again, a very, very tight calcified stenosis. Again, a wire capable to navigate this vessel, very bad and so calcified vessel. And after the support with a micro catheter from Tokai, Japanese micro catheter, you can see it was possible to cross this tight stenosis. And when we have the wire in the distality, we decide to use again a very low profile balloon with a single marker. So the marker is in the middle of the balloon, and to predilate, this is 1.5 2 centimeters Coyote ES Boston Scientific balloon, capable to this very tight stenosis and preparing the vessel for the definitive dilatation. We use a 2 millimeter balloon. In this case, my suggestion is to avoid to dilate too much the vessel, because when we don't have a sufficient outflow, it's better to maintain an acceleration in the vessel in order to have a better perfusion aspect in the foot. And this is the final aspect from the groin of the revascularization. So now it seems to be very well perfused, the amputation, both plantar and dorsal sides. So we were very happy of this result. So again, the strategy in this case was no one vessel, but two vessels in order to supply both sides of this non-healing amputation. Okay, so next case, before to see next case, 2 words about the wire choice and manipulation. So we follow the escalation concept with the wire. So we try to analyze the anatomy and the calcium severity before starting, and then we try to use step-by-step more aggressive wire, and of course using the more aggressive wire for the proximal cap, and then if the tortuosity do not permit the use of the same wire, we have to think how to de-escalate the wire. So we try to use wire more capable to navigate the tortuosity. So the alternation of CTO and navigation wires probably is the best strategy for this kind of patient. This is an example of severe calcification in the distality of the anterior tibial. We try to use the normal hydrophilic 1,4 wire to cross this occlusion, this short calcified occlusion. Of course, it was not possible to cross, so we tried to increase the power of penetration, and we shift from a 1,4 to an hydrophilic 1/8 wire with 8 gram in the tip. But again, it was not possible to cross this lesion. So next step is to become more and more aggressive. So after the 1/8 gram, we start with the 30 grams astato wire. You can see here, we try to maintain the tip in the middle of the calcium, and after many attempts, finally it was possible to cross the occlusion with a support cutter capable to increase the power of penetration of our wire. Attempts, you can see here the final progression of the wire. I remember you, this is a 30 grams wire. So the possibility to go straight and to achieve a perforation with this kind of tip is really, really high. So after I perform the hole in the calcium, I use a 1/4 navigation wire to follow the path I did with the 30 grams wire, arriving finally into the pedal artery. So after this successful crossing, we perform a piercing approach to let the balloon, to help the balloon crossing this lesion. You can see here many punctures again against the calcium, and after this aggressive puncture, it was possible finally to cross with a single marker balloon and pre-dilate all the lesion. I will show you the result after the plain old balloon angioplasty and after the drug elution angioplasty. So when we crack the calcium, it's possible to perform drug elution. The last case I want to run, again, a critical limb ischemia case with a general sufferance of the foot with a lesion in the fifth. Again, a very bad foot condition, a circulatory condition. There is a tight stenosis in the distal AT. So I thought, okay, it will be sufficient to cross that in order to revascularize the anterior tibial to have a nice flow in the foot. One vessel will be enough. You can see the same strategy. So the 1/4 wire supported initially by a Bernstein catheter, we could successfully cross the occlusion with this wire, but in order to improve the possibility to cross with the balloon, we deployed a very long sheet from Cook. It's a 4 French flexor sheet. You can see here, this is the calcium. So again, the wire was capable to cross the last mile, but the catheter cannot. This is a CXI catheter. The catheter cannot cross this lesion. And with the long sheet, while we checked the situation with the contrast medium injection, we achieved a very bad perforation of the vessel. So we realized we cannot leave the patient with this situation, and so we shift into a retrograde distal puncture of the posterior tibial artery in the common plantar artery. Again, the 21 gauge together with the 1/8 wire. This is a V18 wire from Boston Scientific. You can see here the subintimal progression of the dissection. The tip of the wire is twisted, is rotated with the loop. Of course, we could perform a rendezvous technique in order to snare the wire, and so it was possible to pre-dilate and dilate all the posterior, but then we had to continue the revascularization towards the forefoot. This is the common plantar, and I was quite lucky to arrive in the medial plantar artery. So we had a direct flow through the connections and through the collaterals into the forefoot. After this procedure, of course, we treated the popliteal artery and the SFA in order to stabilize the inflow, and I can show you the final results of this aggressive revascularization procedure. This is the good inflow into the popliteal and SFA. Again, we try to stabilize the dissection in the middle with the Zilver-Pittig's stent, and this is the final results in the foot. So you can see the microcirculatory aspect in the plantar, in the forefoot. This is the anteroposterior view. The next one will be the anteroposterior view of the foot. You can see here how we orient the amplifier, and finally this is the direct perfusion of the fifth with a very good blushing aspect in that area, so we could be very, very happy of the procedure. So to conclude, my friend, of course, the strategy should be more aggressive in route 4, 5, and 6, especially when we have big artery disease patients, so with few calcification. And so we can use both techniques, both strategies, subintimal or intraluminal, and even with retrograde, we could be successful. Of course, in this patient, we need to have a patent arch, or we try to improve the arch patency. For sure, we have to be prepared for extreme retrograde when complication occurs, and remember that a little bit of learning curve is needed. Thank you very much for your attention. I stop here.
Thank you very much, Professor Marco. Very, very, very interesting cases. And I leave the mic to Dr. Mahmoud Salah to start the discussion with Dr. Ali Badra.
Dr. Ali, and thank you very much for all of the speakers. I didn't have the chance to welcome Dr. Yusa. Dr. August Yusa is with us. He just joined immediately before I start, so I didn't have the chance to salute him. Thank you very much, and I think we have some questions I can see. I will leave Dr. Ali Badra to run the discussion. Dr. Ali, please.
Dr. Mahmoud, thank you. Thank you for all speakers for excellent presentation. Is there any question from audience or not? Dr. Mahmoud, you have any question? No.
I have one question, Dr. Ali.
I can see some questions from the audience. Two questions for Dr. Marco. The first question is there is a possibility that the percutaneous needle cracking of calcium could damage the vessel more or not?
Yes. No, the problem is, thank you for the questions. The technique was published by Tomoyasu Sato, is a Japanese interventional radiologist from Hiroshima, and he published the possibility to have bleeding in the vessel. For sure, if you perform this technique in a big vessel like SFA or popliteal tract, the complication, the bleeding complication could be, I don't want to say severe, but could be tough to be managed. But in the below the ankle vessel, so I mean common plantar or Sallis pedis, it's enough to put a finger and to make compression after the angioplasty. Normally, we inflate the balloon for a very long time. So, I mean, 5 minutes, 6 minutes, 8 minutes, and together with the finger, we perform the compression. And normally, after 5 minutes, everything is okay. No worry about this technique.
Okay. Dr. Ali, you have a question?
Yes, for Dr. Ahmed Effendi, endovascular treatment is first choice for us for below the knee lesion. Is there any indication now for open surgery?
Indication for open surgery when is the endovascular. Yeah, hi. First of all, how are you, Dr. Ali?
How are you, Dr.
I can't really find an absolute contraindication or indication for many things regarding revascularization unless it is impacted on the general condition of the patient or the limb. For revascularization of the lower limb, sorry, the question was the contraindication or the indication again?
No, that's the indication of, is there any special indication of open surgery or we reserve of case of failed of endovascular?
Open surgery to be very honest, it's depend on the surgical and the center institution and the surgical experience. In a younger patient, I prefer it rather than in elderly patient because the patency rate is higher. The outcome is better, and the avoidance of the contrast also in if the patient has some kind of a contrast allergy or renal impairment. Not yet in the dialysis. That's for me will be the indication for open surgical revascularization of the lower limb. Young age and risk of renal impaction.
Okay, I agree with you. Thank you. Dr. Manzi.
I'm here.
How are you?
I'm very good. Thank you very much. And you?
Thank you. Your preferred wire 014 or 18?
Well, for tibial vessel, when we don't have so many calcifications, I start always with the 1/8 wire, just for tibial.
Like us. Yes.
Yes. When we arrive in the ankle level, I normally try to change the wire with a 1/4, especially if there is a need of navigation into the arch or into the distality of the foot. So I shift to the 1/4.
And you reserve separate technique, retrograde, if you fail to cross from antegrade. Yes?
Yes. Yes, this is, in my mind, has always been, retrograde has always been a sort of a rescue procedure,
technique.
something like a last resort technique. But together with Mariano in the last during the last years, we realized that more than 30, 35, almost 40% of the patients are actually approached by retrograde because we are much more confident with the technique, probably because the patients are worse and worse and worse, probably because the severity of the disease has been improved. So I would like to say that retrograde approach is no more only a rescue procedure, but we could consider the retrograde approach even in election to treat some kind of lesion or some kind of situation.
Do you have any tricks to do your re-entry by retrograde approach or not? To re-enter?
No, yes, no, re-enter is, the concept is that when you go subintimally, you are in the subintimal space from retrograde, and you are in subintimal space from antegrade. So different planes in both directions. But because if you were in the same plane, you re-enter immediately. But that's
Absolutely.
of course that's impossible. Or no, it's possible, but you have to be really, really lucky. And the lucky is not scientific concept. The problem is that the progression of dissection from above and from below is spiral. So you create a sort of DNA scale. You know, when you have this kind of progression from above and from below, you can see here. Yeah. So you may have more than one point where the two planes are really, really closed, and it's enough to look for with the two support cutter where you have this point very, very close, trying to re-enter there, and probably a communication still exists there. It's only a question of time. Hi, August.
Hi, Marco. How are you doing? Can I just ask you, I've just seen you and follow your algorithm for a long time in terms of approaching the lesions, interluminal, subintimal, and then retrograde. But now, actually considering the retrograde or the plantar as a choice. Can you hear me? Okay. So my question is, do you think that we need to switch from the interluminal to the retrograde and thereafter the subintimal due to the fact that we don't have amazing tools to deal with dissections and that sort of stuff in BTK, BTA?
Sorry, I've lost a question because of the rumors.
Mic is open.
Yeah, can you hear me? Hello? Can you hear me?
Yes, we can hear you. You can say your question again because Dr. Marco couldn't hear it.
Sorry about that.
I couldn't hear you. Yes, now yes.
Okay, fine. Now I was just wondering that since you have just considered recently moving to the retrograde approach as a first choice therapy, if you would consider at some stage to move in your algorithm from interluminal, subintimal, and then the retrograde, given the fact that we don't have amazing tools to deal with dissections when you perform your subintimal recanalization. So at the FEMPOP segment, we have switched to this interluminal retrograde and thereafter subintimal. And I would love to know to your opinion with regards to this algorithm, new algorithm.
Yeah, probably you could be right, because the confidence with the technical and with the skills when it becomes routinary, so you can approach quite easily the retrograde approach. You could consider the retrograde intraluminal since the beginning, in the below the knee and in the below the ankle. Of course, I always have to consider the clinical situation first. So the weight and the aggressivity of the procedure should be for sure related with the severity of the clinical condition of the patient. So in the algorithm, there is no mention the clinical situation, but in our mind must be always present the clinical situation. So I agree with you, and in the normality, in the common practice, I think it's already shift in this way.
Mm-hmm.
Any other questions, Dr. Ali?
I guess there was one question, Dr. Ali. One of our audience is asking Marco about if he is using drilling technique or rotation technique. And the other question is how far you should keep your support catheter from the tip of the wire.
Okay. It doesn't matter if you rotate continuously the wire clockwise or anti-clockwise. It's not important. Or if you do 180 and 180. In my experience, I try to rotate continuously, just to drilling, and never push the wire. Just rotate. The wire should be able to advance by itself. This is the first technical tip, because if you push the wire, you may damage the tip. You may create a loop, and you may cause an unwell dissection. So you can lose the possibility to perform the intraluminal recanalization. The second question is about the distance from microcatheter to the tip. Of course, the more they are closed, the more you have support and power of penetration with the wire. Sometimes the microcatheter cannot be advanced, so this could be a problem. But if you have the wire already crossed the lesion, you can snare the wire with the retrograde puncture. You can crack the calcium with the piercing technique. You can do something else. As Mariano, my friend and colleague, used to say, no crossing, no party. So the first you have to do is crossing the lesion.
Thank you very much, Marco. Dr. Ali, if you don't have any other questions, we can move to the second session. It's up to you.
Okay, no question.
طيب, Dr. Ala, can we start the second session, please?
Yes, Dr. Mahmoud. We will start the second session with the professor, Dr. August Yuza from Spain. He's a consultant of vascular surgery department in the hospital D. Crosses, and he will talk about the tips and the tricks while performing peripheral deep venous arterialization.
Okay, thank you so much. Can you see my screen?
Yes, it's clear.
Excellent.
Yes.
So thank you very much for your kind invitation. It's always a risk to follow Marco Manzi in a presentation because you are at high risk of get your audience aboard, but I will try to do my best. Let me just start just giving a huge hack to Fernando Gallardo, who has not been able to attend due to a COVID issue. So let me start with my presentation about tips and tricks with regards percutaneous DVA. These are my disclosures. So my first tip is to choose the right candidate. Don't be in a rush because this is not for acute limb ischemia. So take your time to choose an appropriate candidate, exclude huge infection or severe necrosis, and choose real no option patients, because you may feel tempted to overindicate the procedure, but always keep in mind that this 60 to 7% limb salvage rate that has been reported in the literature has the other side of the coin, which is a 30 to 40% amputation rates. So these are the major contraindications reported in the trials, but as you can see, you always need to be mindful about the psychological and the social condition of your candidate, because the wound healing is going to take longer than in standard revascularization arterial procedure, at least 4 or 7 months. With regards to our workup, we always perform an echocardiogram to assess the heart function, an angiogram, a thorough assessment of the venous system, specifically focusing on the foot, and a baseline TCPO2. And this is really crucial. You need to be familiar with the anatomy because it has nothing to do with the arterial one. We have two systems, the superficial one with the main player, the great saphenous vein and the medial marginal vein, and the deep venous system with the posterior tibial vein. This posterior tibial vein connects with the plantar vein with two branches, the lateral plantar and the medial plantar, and the lateral plantar connects with the arch at the level of the first, fourth interosseous space, and this arch receives the drainage of the metatarsal veins and in the interosseous veins. And these systems, the superficial and the deep venous system, are connected with perforators. The main one is perforator number 6, localized at the level of the first interosseous space, avulvulated, and the main drainage is the first two main vein with 2 or 3 valves. The first thing you need to decide is whether you're going to perform DVA on the superficial venous system or in the deep venous system. If you're thinking about to perform a DVA in the superficial venous system, you need to look for a vascular surgeon because the distance from the great saphenous vein to any main branch is too big to consider a percutaneous procedure. So if you're thinking about to perform a deep venous arterialization in the deep venous system, I would recommend to use the posterior tibial vein due to the connection, the direct connection with the venous plantar arch. And the other thing you need to decide is whether you're going to perform a proximal or a distal DVA. If you're thinking about a proximal DVA, you will have an increased flow, but you will need some cover stents, and definitely you have an increased systemic effect and increased Still syndrome. Whilst if you are considering a distal DVA, no stents at all, nevertheless, you will need to assure that you have a good inflow to maintain patent your DVA, and your systemic effect is going to be decreased, and the Still syndrome is also be decreased compared with the proximal one. And if you have a look to this review published last year in the Journal of Vascular Surgery, you can see that the limb salvage rates and the wound healing rates are pretty similar, regardless the location or the way you perform your connection. So it seems to be related to everything but the whole. And where do you need to place your hole? I would say you need to perform a flavoangio to locate the best spot for the connection. Try to avoid calcification and always try to avoid excessive distance between both vessels. My recommendation is to perform the connection distal to the main branches in order to avoid the Still syndrome, the arterial Still syndrome, and as Miguel Montero mentions, always try to keep a good balance between the remaining arterial network and your DVA. And from a technical point of view, this is the first maneuver, getting your venous axis, and this sometimes is really a pain. Sometimes it's really tough, time-consuming. What we do is to perform it under ultrasound guidance with the tourniquet, and our target are usually the posterior tibial vein or the plantar veins. Alternatively, you can use a direct puncture of the venous plantar arch. That's going to be easier when you try to advance your catheter through the plantar valves. So that's going to probably make this procedure more straightforward. And as you know, there are different ways to perform your connection, either a proximal or distal. In the proximal, you can use a dedicated device, the lymph flow device, or an off-the-shelf device in a lymph flow-like way using re-entry catheters, available re-entry catheters like the ODVAC or the Pioneer ultrasound catheter with the people technique described by Bruno Migliara. And if we talk about distal DVAs, you can use the catheter and wire maneuver or the spiral technique described by Shigeo Ichihase. And among them all, you can also use our technique, the venous arterialization simplified technique, to perform either a proximal or a distal DVA. So specific features for proximal DVAs, you need to keep in mind that you definitely need a stent to focalize the flow towards the foot. For the crossover stent, you can use a dedicated stent in the lymph flow system, or alternatively, you can use it an off-the-shelf using a cover, balloon expandable cover stent, nothing less than 3.5, because otherwise you will compromise your patency. And then in the venous segment, you need to flare this segment in order to accommodate the extensions with the cover stents. So we use self-expandable cover stents for the extensions, and we prolong these extensions up to the level of the calcaneal area. This is important because you want to avoid bleeding up from collaterals and treating the valves, and then reaching this calcaneal area, try to overpass the lacerated ligament in order to avoid compression. And finally, I would recommend not to deploy this stent before reaching the plantar arch, because otherwise you can end up in a cul-de-sac condition that may probably be pretty annoying. So if we talk about the limb flow device or the limb flow-like maneuvers, I would say that a good way to simplify the procedure is to use a snare to capture the wires, because this makes the procedure quite straightforward. And in fact, the limb flow device has jumped to this sort of approach, and they have eliminated this ultrasound alignment of the catheters. Another issue with these devices is that they are pretty bulky, 6-7 French, and this can be an issue when you're dealing with small and tortuous vessels. And I always wonder why not to turn the whole thing upside down and get access through the venous side. You can easily access with a 6-7 French and then deploy your needle from below. And if we talk about distal DVAs, thinking about the catheter and wire maneuver, the main issue is that Roberto Gandini, who published this technique, reported a 20% failure rate of the connection, but this has been nicely overcome by Mariano Plena, who uses another wire inside the vein as a landmark for your to locate the vein and then to cross with your CTO wire into the vein from the artery. And if we talk about the venous arterialization simplified technique, the VAS, one of the quite common questions we receive is if it's easy to cross through these two snares. I would say that this is a pretty straightforward maneuver, but my recommendation is try to get this spot image in order just to cross perpendicular to both snares and then switch to the lateral view and assess that both the snares has just been crossing. And then we advance a quite soft wire, O14 wire. It can be either a command or the Advantage O14. And you can also use a ghost neck, a snare, or a trill of 1 for 5 millimeters, probably enough. Another common question with regards to the VAS technique is that if the O14 wire in the non-floppy area can be bent by the second snare. To be honest, we never had any issue, but if you are concerned about that, you can always use a support catheter in order to reverse the position of the wire, and then you can catch the tip of the wire at the floppy side with the second snare. And some of you probably are vascular surgeons, and you may consider to perform this in a hybrid condition. This is pretty fine. I would say this is a low-cost procedure, but definitely you need a conduit, either the great saphenous vein or prosthesis, a PTFE graft. This has been reported by Roberto Ferresi. The main issue with a PTFE graft is that you may be dealing with an infected field, and this can infect the graft itself. And you can perform this hybrid procedure either in the great saphenous vein, medial marginal vein, as Lengua reported, or in the posterior tibial vein in the Monteiro-Gura procedure. The main issue with these hybrid maneuvers is that you are performing cut downs in an ischemic leg, and this can lead to some gun issues. And this has been overcome by Andrea Cassini and Roberto Ferresi with this single cut down approach. And at this stage, they perform the anastomosis, the proximal anastomosis, and then all of the endovascular procedure is done from this axis. One question that arises during our prior cases is when you are performing a Lengua procedure, a hybrid on the great saphenous vein, if it's really necessary to get access to the plantar arch. So at this stage, we ask directly to Andrea Cassini, and the feedback was amazing. He answered that just leave time, get pressure into this valve, and this will render the valve. And as you can see, he was absolutely right, and this is the outcome. And this is why I really love the social media interaction, because it permits to contact directly to any key opinion leader worldwide to make your questions and to get information about any sort of procedures. And what about if you don't have a vascular surgeon available? Well, this is really amazing as well. This is from Bruno Miglana, recently published, the super safe technique to connect the superficial venous system with the posterior tibial artery. So based on the VAS maneuver, he places a snare in the great saphenous vein, a second snare in the posterior tibial artery at the origin, and with a long needle, 15 centimeters needle, he pierces both the snares. Then he progresses a wire and then close and retrieve both the snares, and through this through and through wire, he deploys a self-expandable cover stent with this amazing outcome. Then once you are already on the foot, you need to cross the remaining valves of the lateral plantar vein. So at this stage, this is really important. You need to be, again, familiar with the anatomy and really need to be really gentle because they are quite spasmodic vessels. And if you end up in a sort of a spasm, I would recommend to put a bolus of nitro, which is pretty effective. We cross this valve using a Western catheter and loop wire maneuver, poking into the valve and then crossing the valve. But alternatively, you can also use the dancing wire maneuver from Roberto Ferresi. Alternatively, if you have issue with crossing the valves, you can also just press the forefoot in order to open the valve, or use the dual axis, bidirectional axis, like in this image from Lake Raja, or you can also use the lesser saphenous vein. This is what we have been doing recently, and hopefully this is going to be published soon in a journal. The axis is pretty straightforward because you just need to puncture ultrasound guided at the level of the malleolus, and this can make your crossing the valve, make your life a lot easier, as you can see on this image. And once you are in the lateral plantar, you need to reach the plantar arch. We sometimes receive these sort of images as a consultant of this procedure, but this is completely useless. You need to get access into the plantar arch because you need to drain all of the blood on your target wound. So don't give up and reach the plantar arch. And once you are in the plantar arch, you need to drain this plantar arch into the dorsal vein, the first dorsal vein, because otherwise you will have this roundabout effect of the flow without any increase of perfusion of the forefoot. And finally, you also need to destroy the valves. And for this, you can use a dedicated device in the lymph flow system. But why, if you don't have the lymph flow device available, like in our case? Well, I always wonder why not to use a long sheath and just progress up to the level of the artery and then progress inside a standard surgical valvulotomy and then open, retrieve your sheath, long sheath, open your valvulotomy and retrieve both the valvulotomy and the sheath simultaneously as a standard surgical valvulectomy, and this may probably be quite useful. Alternatively, you can use an angioplasty balloon, non-compliant balloon, cutting balloons, the double wire maneuver from Roberto Ferresi, excimer laser, or even the Pierce technique as Marco Manzi has described. Good consideration is try to avoid overstenting the foot because the stents can be crushed and this can compromise the patency. Although some colleagues have reported good experiences using Supera or even drug-eluting stent, like in the case of Stephen Kuhn himself. And finally, really, this is important. Try to avoid flow focalization during the initial procedure because you can end up having a devastating situation, which is the extension syndrome related to the compromise of foot evacuation, foot venous hypertension, and necrosis. And once you have your DVA already working, you need to face the stump after DVA, and this is related to the shunt, to the AV shunt. This increases the overload of the venous system and increases the ischemic still syndrome. We put all of these patients under an anticoagulation regime and a single antiplatelet therapy for at least 3 or 6 months. We treat the pain with regular painkillers, occasionally epidural catheters, or at the compressive guillotine TMA. swelling and cyanosis are usually an issue, and the best way to deal with swelling is just early emboliation to activate the Lejar's system, leg elevation, and occasionally diuretics, and perform limited surgical debridements if needed in case of wet gangrene or access. Or in this case, we usually keep the head of the metatarsal bones preserved in order to avoid osteomyelitis of these bones. But keep in mind that all of these debridements following a DVA are usually quite a pain because you have quite a venous hypertension. And finally, with regards to postoperative follow-up, we follow these guys every single week, assess pulses, TCPO2. We perform every 2 weeks an ultrasound just to assess the flow. Any flow lower than 100 may arise any suspicion, and we put these guys, we take these guys to the OR to perform an angio. We also perform angios 2-4 weeks following the procedure to focalize flow by using coils or either with the graft-venous-based ligation on the local anesthetic. And we also wait up to 6 to 8 weeks to the remodeling of the venous system to perform our final amputation. And if needed, we always use tension-free skin graft. So that's all from my side. Thank you very much for your attention. If you have any query, just contact me on my email account or in social media. Thank you so much.
Thank you very much, Dr. Yusa. Dr. Ala is back.
Yes. Thank you very much, Dr. Yusa. Yes, I'm here already. So the next presenter is Dr. Mahmoud Salah, the head department of the vascular surgery in Saudi German Hospital, and he will talk about the difficult situation in the BTK intervention. So, Dr. Salah, the mic is yours.
Thank you very much, Dr. Ala. Can you see the slides?
Yes, doctor. Yes, we can see the slideshow.
Okay, actually, I'm going to talk about some cases or some situations that we had been through doing our cases. So the first case is 40 years old male have critical limb ischemia with swelling of the popliteal area. He gave history of trauma few months back, actually a couple of months, and he did CT angio, and we had a surprise. This is the angio we had. This is a complete occlusion of the popliteal artery with this huge aneurysm. You can see this is during the angio. You can see the huge aneurysm and the flow inside. We actually tried many times to cross from above. Every time we were going to the aneurysm, we could not go through the occluded popliteal. So the only option was to go as retrograde from the dorsalis pedis using ultrasound guidance, and we had the wire coming from the dorsalis pedis up. We crossed the lesion, the popliteal lesion, and we managed to snare the wire from above. So we had the two ends of the wire outside the body, which is, as we call, body floss. Then we did ballooning of the popliteal artery. And this is the result. You can see now we have popliteal artery, but still the aneurysm is filling. So we used actually double supera stents with packing inside. Actually, in such situation, I would prefer to have covered stent, even if we are going to reinforce with the supera. But During this situation, there was some mismatch between the available covered stents and the popliteal artery. So we used this technique of double supera stents. Actually, we had good result. You can see now we have popliteal artery. Still, there is some filling of the aneurysm, but usually this filling close or thrombose within couple of weeks. Another case, we had a 52 years old male, diabetic, suffering of critical limb ischemia with gangrene of toes, and we did CT angio and confirmed that he has infrapopliteal disease. You can see that there is no popliteal and no infrapopliteal, all collaterals. Okay, the only vessel we could recognize or we could see is this one, which is the anterior tibial artery. We don't have even the tibioperoneal or popliteal. As you can see, all collaterals. We managed to go from above using wire and support catheter. We finally reached the mouth of the anterior tibial artery. Then we did a ballooning of the popliteal artery. Once we did balloon, we have recognized the mouth or the place of the takeoff of the tibioperoneal trunk. So we managed to go also in the tibioperoneal trunk with a wire and support catheter. Now we had two wires going to the anterior tibial and tibioperoneal, going to the peroneal. Then we put a supera stent, and this is the final result. We have very good popliteal and anterior tibial and peroneal. We had at least two vessels. We could not revascularize the posterior tibial. Another case, acute on top of chronic ischemia. This is a very critical foot, as you see, and the angio was very strange. You can see very diseased vessel. The one on the left, you can see lesion in the femoral artery, and then in the middle, complete occlusion of the femoral, and the only two vessels could recognize was the anterior tibial and the peroneal artery. We used atherectomy device. We used the jet stream, and you can see very strange angio, but finally the lesion was crossed, thanks God, and this is the angio. You can see a diseased vessel, but at least patent now. The posterior tibial could not revascularize from above. We managed to go from the anterior tibial to the posterior tibial using balloon as a support, and then the posterior tibial was reached to the tibioperoneal trunk, as you can see. Then we managed to use again the atherectomy device in the posterior tibial, and we had the three vessels revascularized. Another case, we had a case of critical limb ischemia. Again, the CT angio showed severe infrapopliteal. Dr. Ahmed, I think, touched this case because we did together. There is no vessels apparent except the mouth of the anterior tibial. Again, this is the popliteal and this is the anterior tibial, and after that all collaterals. We tried hardly to go from above, but actually there was no luck. we had perforation, we had dissections. So the only option we had was to go through the dorsalis pedis again and having the wire, and then the wire was captured by the vertebral catheter in the mouth of the anterior tibial, then ballooning, and this is the angio, and this is the final angio. Another case, we had acute thrombosis that occurs during the procedure. You can see the arrows is showing thrombus in the anterior, in the popliteal and in the trifurcation. The contrast was not going because of the thrombosis. Actually, we had trials of aspiration, and this is what we got. Actually, we got, as you see, thrombus from the vessels, and by repeating the procedure, we got many of these thrombi, and the vessels were cleared, and this is the final angio. Below the ankle, angioplasty. This is something that we all face, and sometimes very difficult. This is complete cut off of the anterior tibial artery. There is no dorsalis pedis, and there is no arch. We managed to go by the wire, crossing to the arch of the foot, reaching to the beginning of the posterior tibial or the medial plantar, and then we used a balloon for the dorsalis pedis, and this is the final angio. You can see both are filling posterior tibial and anterior tibial vessels, and the arch was complete. Another case, this one we had the anterior tibial was complete, but there is no posterior tibial, and the arch was not there. With some manipulation of the wire, making very small loop, we tried not to do, but actually this was the only way we could cross. And you can see one wire from the anterior tibial, and the posterior tibial wire is going through the anterior tibial. Then we used a balloon, as you can see, a very small balloon, 1.5. Sometimes we need a bigger balloon like this because he was a big guy. And finally, this is the final angio, and you can see that the arch is full and the anterior and posterior tibial are filling. The take-home message that infrapopliteal angioplasty equals limb saving, nothing less. There is no chance to do anything less than limb saving. Infrapopliteal angioplasty means limb saving, and it should be done only in critical limb ischemia. We never do it in claudicant patients, for example. These are basics. And to work on this level of angioplasty, we should have patience, persistence, plus experience. Of course, you should have the right material and right equipments, and you should have all the materials to face any possible complication that can happen. Thank you very much.
Thank you, Dr. Mahmoud, for your nice presentation. And let's move to the next topic from Professor Martin Stor. He is the director of the Vascular and Thoracic Surgery Department in the University of Freiburg in Germany. And
Hello, everybody. Can you see the slide and hear me?
Yes, we can see you and can hear you.
Yes.
Martin, how are
dear
you?
colleagues, dear audience, dear Dr. Mahmoud, it's a pleasure to be invited again to this webinar. I have been visiting some departments of the Saudi German Hospital Group in Saudi Arabia and Cairo, and I was really convinced about the high quality of the vascular surgical department, especially in Jeddah, and I was honored to be there a couple of times and give lectures. So this time we have the topic acute ischemia, and you have seen already a few cases by Dr. Mahmoud. I'll try to go on. And I would like to give you some more theoretical undermining of how to decide. The problem in acute ischemia is we have to make quick decision what to do with the patient, which therapy is best, and which direction we go. So usually, first, what we have to do is we have to really define the degree of the ischemia to really make sure, is it a viable extremity, which is not immediately threatened, where we have some time, we can plan, even sometimes to the next morning, or is it marginally or immediately threatened? And you see there, the red line is the border between endovascular and surgical a little bit. I think this line has shifted down a little bit more downwards in nowadays, because we have more and more options of endovascular treatment, even in this critical ischemia, acute ischemia, as we should say, actually, with tissue loss, of course. And the choice of the method is also dependent on the comorbidities of the patient. I would like to show you a few examples where it's not a good idea to go endovascular in some cases, but maybe surgical treatment might be preferable. So what we have to find out, if the patient presents, what is the underlying etiology? And most of the cases is cardiac embolism, of course, or arterial embolism. We have seen this, but there's also more and more cases of acute bypass and stent occlusion. That means previous vascular procedures and complications can lead to acute ischemia of the extremity. And then, of course, we have to do something. Also, thrombosed popliteal aneurysm, which is a special condition, but we have to know before you start treatment that this is present. Also, there is something local arterial thrombosis, that means pre-existing disease, and all of a sudden the vessel occludes and is thrombosed, comparable to myocardial infarction, and a lot of other things like entrapment, injury. And you see here more and more theoretical, possibly conditions that can mimic acute ischemia. And so you have to make a very good patient history. You have to take your time and really find out about previous diseases and previous procedures in the patient, and make a sufficient diagnostic before you start to do something. This is, of course, for our medical students, what we do is, of course, pulse, Doppler pressure. Is the pulse regular? We can already find out by just touching the patient. Is it an arrhythmic patient? But then, of course, we do immediately the duplex scan, and then we do more and more diagnostic if necessary, and some lab diagnostics like myoglobin, for instance, to creatine kinase, to find out tissue damage. The magnetic resonance tomography is actually only a thing where you have some time to really make a picture. They have advantages and disadvantages. The good thing is no X-rays, radiation is there. It's a good overview from kidney to toe, and you have no iodinated contrast medium, which is very important for patients with renal insufficiency. And most patients, elderly patients with diabetic complications, they also have renal complications, and then you have to really be careful with contrast medium. Up to a certain amount, it's no problem. And of course, there is this nephrogenic systemic fibrosis. I think this can be neglected, but if there's any metal in the patient, it's getting complicated. Of course, it takes too long, actually. CTA goes faster, or a good duplex scan. But you've seen something like this before in Dr. Mahmoud's presentation. This is a really pale extremity, and the patient has pain, and so what to do? So the first case I would like to show you, just to make this complete, is the thrombosed popliteal artery aneurysm. You see here a very aneurysmatic changed degenerated artery and a completely thrombosed popliteal aneurysm. In some patients, there is thrombosis of this aneurysm and they have only claudication, and that's no big problem. But if this was with acute ischemia, and here on the other side, you see a bypass, but below the bypass, there's also an aneurysm developing. So nobody ever touched the knee in the years before, so there was a really huge aneurysm. and it was treated with a vein graft from the femoral to the below knee, and the other side needs to be treated sometime later on. It is a theoretical possibility to do a preoperative lysis, but you can also do on-table lysis. Sometimes the runoff is so poor that the bypass doesn't really work. So we have some complication rate up to 30% in these patients. And I would like to show you the actual recommendations of the European Society of Vascular Surgery published last year for acute ischemia. And they really recommend on the class 2A level, which is not too bad, for patients with acute limb ischemia secondary to thrombosis of a popliteal artery aneurysm, it should be repaired with saphenous vein, should be considered. Should be considered is a quite strong recommendation. And also it says for patients with acute limb ischemia secondary to popliteal artery aneurysm, that thrombolysis should be considered. It means before or most of the times afterwards. But you see here the literature is a little bit older, from 2007. So this problem is a problem which has to be recognized before you do something with the patient. But also I would like to show you some other cases. This is a very long anterior bypass. This patient has been treated in other hospitals with many, many stents. From the AFS down to the ATA, there was a lot of the original vesicle is occluded, a lot of stents, and he has a bypass. So the question is, do we do this by endovascular means, or should we do a quick thrombectomy of the bypass? The bypass needed a patch in the distal end, and the foot was treated by adjuvant lysis. So sometimes in these cases, if this ischemia is not very fresh, but a few days old, it's maybe makes sense to do a little bit lysis for 24 hours and then make a second look, and then you see his runoff with the anterior tibial artery down to the foot, but there's not many vessels left. Unfortunately, if you do lysis, you can have some bleeding, and it needs to be, the patients need to be monitored very closely. This is a very old-fashioned, old-style surgery. Was like more than 10 years ago, I think 15 years ago in Leipzig, when I was working in the other hospital in the beginning of 2000s. We had to do a thrombectomy and we couldn't open it, so we did it retrograde, but not in the elegant method as you see before with a needle, but this was a very small Fogarty, which worked well. But nowadays, I think we would not do this anymore. The retrograde Fogarty is obsolete. You would probably puncture this vessel and then try to capture the wire, as you have seen in the previous presentation. This is an example of upper extremity acute ischemia, really pale hand. And in the case of the hand, it's very important to make quick reaction to restore the perfusion of the hand. And this is also very historical, because nowadays we would not make an angiogram to verify this, but so I want to show you this picture, what it looks like. You see a very sharp cut off edge here. So we decided to make a very quick transbrachial thrombectomy, take 10 minutes in local anesthesia, and it was finished. So there is not much effort to do this sometimes in the OR. And here you see the reason, it was a thrombus in the atrium. Problem is, if the patient presents, you see this patient 79 years old with bilateral acute limb ischemia. This was predominantly in the right leg with a 2A stage Rutherford. That means still viable, but quick action is needed. And he had also arrhythmia and a lot of big thrombus load. And of course, you can do aspiration and thrombectomy with the Rotarex, but the Rotarex sometimes doesn't go down to the lower extremity. So we did a thrombectomy, and we did also lysis for 24 hours. And then in the second session, after 24 hours, we dilated the artery down to the middle third of the tibial artery, and then we had one vessel runoff to the foot. So again, an example for combination with thrombolysis. I know this is not very popular, the adjuvant thrombolysis, but in cases like this with a very huge thrombotic load, we do this sometimes, and next day you can finish the intervention. This is another case, 91 years old. Patients are getting really old nowadays. See complete occlusion of the popliteal artery. This is very poor collateralization, very acute, and was treated with a Rotarex that went through here to the third popliteal segment, in addition also with PTA and lysis after 24 hours, but could be completely reopened. And of course, in a patient of that age, the older the patient gets, the less surgery or less invasive we want to be. So actually, this is a standard treatment nowadays to use aspiration or Rotarex system or other system for thrombus fragmentation and aspiration. This is another case where surgery might make sense if the common femoral artery is involved. It's sometimes difficult. You have to actually go cross over, but you see the other side is also not very healthy. And this patient had some special conditions. That's why I'm showing this to you. Multiple comorbidities and renal failure, urosepsis, bladder cancer in history, and always occlusion of his catheters, PCN catheters. He was on anticoagulation, had twice lower GI bleeding under triple therapy for myocardial infarction. And then he was switched from Xarelto to Pradaxa. And in this case, we decided to do a small cut down in the groin and do this in a classical thrombectomy way in one-stop shop in surgery, and was discharged at day 6 without any complications. So we were lucky. Was a female person here, 85 years old, very old. So what are the results now? And if you compare acute ischemia and critical ischemia or claudication, this was put together here. That means the really acute cases or the chronic cases, you can do both. You can treat them no matter how you treat. Treatment modality is, they have the similar comparable results. And it seems that acute ischemia even has better results if you consider freedom from re-intervention. That means very important to make a complete revascularization with other method you choose. But in this case, there was some bias in the publication because in the group A with acute ischemia, there were 40% popliteal artery aneurysm, whereas in the chronic group, only 4% popliteal artery. This might influence results because if you treat this, as I showed, by surgery, of course, you have a very good long-term result. And the interesting thing is that the long-term results depend a little bit on the etiology of the occlusion. So you see here thrombosis, embolus. If you have embolic occlusion and you can reopen it, you have a very good long-term result. But if you're getting worse, you see the blue is thrombotic occlusion. Then you have popliteal aneurysm. And here you see graft stent occlusion. This is progressive atherosclerosis, progresses over time. And the prognosis of these patients, as we have seen today in the very first presentation, is really low, also regarding amputation-free survival, as you see here. It's a difference what the etiology is. And here you see the popliteal aneurysm still is the best considering amputation-free survival. And here you see the method you use. Very interesting. This is one of the few papers I found where they compare surgery versus interventional treatment, but it's a retrospective study and they always have some selection bias. There's only 2 prospective trials, but nobody is repeating them. The STYLE trial and the TOPAZ trial, very old. They show no difference, but here you see if the bypass thrombosis is treated or if it's a embolic occlusion, it makes a difference considering the patient. This is patient survival, and this is survival if you compare endovascular and open revascularization. But this also shows you that these patients that are routinely treated, you see here 36, 2/3 can be treated by endovascular. That means if they are healthy enough or the lesion is not too complex, as we see in the examples before, if we have a chance to open them revascular, endovascular means they probably on this curve and with a better survival curve, after 5 years, you see there's still about 60% long-term survival. Something which have not been discussed today a little bit, but drug-coated balloons. I think one presentation mentioned this is a hot topic still a little bit, at least in Germany. We have to inform the patients when we use them and tell them that there was some critical meta-analysis, but all registers and recent follow-up publications could actually not confirm the danger of this, but still the patient has to know. I think in very highly calcified lesions, you need to do atherectomy before you use this balloon. Otherwise, it's a good idea to use this to prevent restenosis. But for time reasons, I will not go too much into that. Another interesting topic is if you do percutaneous thrombolysis and or aspiration, there's a significant number of patients that they need additional procedures. This is usually not published. There's some open revision or hybrid revision, and at least some patients, 16% have major bleeding and some need fasciotomy. This is very interesting, especially patients with diabetic problems. They have a worse outcome. You see here, you have higher amputation rates and less higher death rate after 30 days if they are treated with thrombolysis or percutaneous revascularization, if you follow them. And of course, we have to consider the contraindications for thrombolysis. You see, I talk a little bit about thrombolysis because it's a dangerous thing, actually. There's a lot of contraindications, major and minor. I will not go through that, but it says here in the recommendation of the ESVS that the risks are dependent on the individual physician practice and experience. So if you have experience with thrombolysis and you have the chance to monitor the patients, then it's not dangerous. And the recommendations of the ESVS last year is that patients who are undergoing thrombolytic treatment for acute limb ischemia should be monitored for vital signs, access complications, and the condition of the limb, continuously monitored in some ward where there is somebody looking after the patient every hour. And also it's recommended that it should be stopped if major bleeding occurs during treatment. So if it's bleeding, you have to stop the thrombolysis because the bleeding has to be taken care of. Also, there is a question, which thrombolysis, what should we use? Should we use urokinase? It hasn't been available for the last years, but it's now back. Or RTPA, actually we switched completely to RTPA in a lot of studies showing that some bleeding complications, you see here 11% or 8%. So it's around 5 to 15% complications with major bleeding, which you have to keep in mind if you do this. If you are able to do a complete thrombectomy without the need of thrombolysis, might be a big advantage. So finally, how to decide, that was a question of this presentation, what to do. This is a recommendation 10 years ago. You see here again the border between 2A and 2B ischemia. And I put the red spots on surgery. If it's immediately threatened extremity, you have to be really quick and fast with a removal of thrombotic material, or you have multi-level occlusion, then it's better to do surgery. If it's irreversible, of course, sometimes it's primary amputation. And then down here it comes again. If there is an angiography, if you do an intervention and it's incomplete and it's underlying lesions, multiple extensive, then still a bypass, also secondary bypass, can be necessary to really restore the perfusions. In some cases, of course, we don't show these cases on these meetings, but in some cases, it's not possible to reopen everything by endovascular means. But as we saw from Italy, there's a lot of improvement, technical improvement now. So here it says catheter-directed thrombolysis, and if it's complete, you can afterwards or primary do the endovascular surgical angioplasty or anticoagulant therapy alone if there is nothing left to do. This is a more pragmatic recommendation last year in the ESVS. It says you have to first make a classification, then you do some imaging, CTA or duplex or whatever you choose to do. And then it says selection of best treatment. This is very interesting because this is open to the individual physician. And then you decide what to do, endovascular or surgical, or switching techniques or combining hybrid procedures. You can open small cut down and still do endovascular interventions further down. We have seen this also. Sometimes it makes sense to do a hybrid procedure. And then you always need a completion imaging to really have a documentation of the final result. So this is in short about acute ischemia, and I thank you very much for your attention.
Thank you very much, Professor Martin. Very elegant presentation regarding the acute ischemia. So let's move to the last session, the last presentation in the second session by Mrs. Shaima Abdul Wahab, is a nursing educator in Saudi German Hospital, Ajman branch from the United Arab Emirates, and she will talk about the nursing management in the diabetic foot ulcers. So, Mrs. Shaima, you can start.
Hello, good evening, everyone. Hello?
Yes, good evening.
Yes, we can hear you. Please.
Okay.
Yes.
Sorry. Okay. First, today we'll speak about the nursing management for diabetic foot. Briefly, I will speak about the diabetes mellitus, and then we will go for the diabetic foot care, prevention, amputation, and the nursing care before and after the amputation. So first, we'll start with the diabetes mellitus is a metabolic disorder characterized by elevated level of glucose or hyperglycemia resulting from defect the insulin secretion or insulin action or both. There is 3 types of diabetes: type 1, type 2, type 3, gestational diabetes, sorry. And for type 1 diabetes, the risk factors for this one is genetic or environmental factors like viruses. Type 2 diabetes almost is related to lifestyle, overweight, obesity, like physical inactivity. Gestational diabetes related to always hormonal changes for pregnancy with lifestyle. The clinical manifestation of diabetes is tired, frequent urination, thirst, sudden loss of weight, always hungry, vaginal infection, sexual problem, and delay in wound healing. Assessment and diagnostic method of diabetes usually is by lab test, fasting blood glucose if is more than 126 milligram per deciliter, random blood glucose more than 200 milligram per deciliter, glucose tolerance test is more than 200 milligram per deciliter, and of course HbA1c.
Ms. Shayma, معلش, let me interrupt you. We can skip the very basic part of what's the diabetes, and we can concentrate on the nursing.
Diabetic food.
Yes, nursing.
Okay, of course.
Diabetic food.
Okay. So we will just go for briefly for diabetes complication. The most complication of diabetes is diabetic foot. Diabetic foot is ulcer begin with a soft tissue injuries of the foot because of the loss of sensitivity of the nerve of the patient with diabetes. So patient with insensitive foot don't feel the injuries, which is cerebral, chemical, or traumatic. Diabetic foot care, like what is the basic diabetic foot care? What I should advise the patient if the patient is diagnosed with diabetes. Wash the foot daily, dry it properly with soft tissue, especially between the toes. Feel the bumps or temperature changes. Check it with the mirror and between the thumbs and the toes. Of course, when we are cutting the nails, make it straight. Check and dry the cracked skin. Examine the bottom of the feet and track everything. If the patient didn't follow the previous instruction properly, this means we will have injury or we will have diabetic foot, starting with non-open lesion and related to later on to grade 5 gangrene. And gangrene has the treatment of gangrene is usually involves the bed rest, antibiotic, and debridement and amputation. Amputation is the removal of body part, often an extremity to relieve the symptoms, improve function, improve quality of life. Amputation may be necessary to prevent the spread of infection because of the gangrene. This means sometimes it's uncontrolled controlled spread of the infection. This means we need to amputate the infected part or gangrene part to prevent to save the patient life and improve the quality of life of the patient, of course. Before the surgery, the nurse should evaluate neurovascular function, and the functional status of extremities through history and physical assessment, assesses circulatory status and function of other unaffected extremity. If infection gangrene, of course, culture need to be taken because there is a sign and symptom of infection, of course, and we need to determine the type of antibiotic. The nurse should be evaluate the nutritional status and create the nursing care plan for the nutritional status of the patient. Of course, X-ray, Doppler, and angiography to determine the perfusion. After the amputation, the nurse has big responsibility regarding evaluate the patient pain because the patient feel pain, of course, after surgery, opioid analgesic as per doctor order, of course, changing the position or placing light sandbag to a residual limb to prevent muscle spasm, promoting wound healing, and this is the most important part because the diabetes patient complaining always of the delay of wound healing and infections. The residual limb must be handled gently. Dressing wound changes should be using sterile aseptic technique to prevent wound infection. The most complication happened after amputation surgery is, of course, hemorrhage, infection, skin irritation, the major or most common one, phantom limb pain, and joint contraction. Our planning for the nurses in this stage, of course, first relieve the pain, including the phantom limb pain, wound healing, help the patient psychological support for accepting the altered body image. Of course, the patient after this type of surgery need most of them need, of course, psychological support, resolution of the grieving process, independent self-care, and restoring the physical mobility, and of course, preventing any more complications from happening. The wound care, first, the wound care elevates the limb which is amputated from 24 hours to 48 hours as per the surgeon instruction. Of course, gently handling the amputated limb with a sterile technique. The residual limb should be measured every 8 hours from 8 to 12 hours after post-operative for any edema. Neurovascular assessment, of course, assessment the temperature, skin color, and pulse sign of infection, any skin breakdown in the site of the surgery or the wound site. Wound dressing as ordered, of course, per doctor. Warping the residual leg after the above knee amputation, elastic bandage to minimize edema. Also, second most complication maybe happen after this type of surgery is joint contracture. Encourage the patient to turn from side to side to prevent flexion contracture, and don't sit for a long time to prevent also the contraction. Leg remain close together to prevent abduction deformity. Encourage the patient to use assistive device as soon as possible. Of course, post range of motion exercise immediately after surgery is recommended as per also of doctor order. It's important that the patient understands the importance of exercising in the residual limb. How to take care of the residual limb? Of course, advise the patient to use the residual limb regularly, inspect the residual limb daily, and can be completed by using handled mirror. Maybe the patient in this time cannot do it by himself, but the nurse rule in this time is to help the patient how to do it independently. Don't shave the residual limb. Don't soak the residual limb for prolonged time to prevent swelling. The most common complication or most common complaint or most common what can I say? The patient always complaining of phantom limb pain. The patient still after this type of surgery of amputation still feel the limb is still there, and how I should deal with this one. Of course, I need to give analgesic. I need to believe the patient he's still feeling that there is pain. Pain may be incisional or may be caused by inflammation, infection, pressure. Muscle spasm may add a patient to discomfort. Surgical pain can be effectively controlled with opioid analgesic. Evaluation of the pain is the most important nursing rule in this time. Patients who have amputation may begin with exercise phantom limb pains after surgery. About 51% to 85% of the patient report a persistent post-amputation phantom limb pain. The patient reports pain in the amputated limb as if it's still present. This sometimes take about 2 years until the patient understand or feel that this part is not long in the body yet. The pain is described if the amputated limb feel crushed, cramped, twisted like this. The phantom pain decreased over the time, but need the previous care of the nurse and support and psychological support and exercise. Epidural analgesic may be used immediately after the operation. Opioid analgesic may be effective in relieving post-operative pain.
Ms. Shaima, 1 minute, please. Please go ahead, but try to finish within 1 minute.
Yes, okay, okay, doctor, okay, I will. In addition to beta blocker, antidepressant may be also prescribed to improve the mood. The most important part here is the therapist besides the pharmacological treatment. It's included in mirror therapy, massage, biofeedback, tense, and virtual reality. As in the picture, this is a mirror inspection or mirror therapy and virtual reality. And here tense. The most also important part, enhancing body image. Of course, the patient after this type of surgery feel bad about himself, about losing an important part of his body. the nurse encourages the patient to look and feel and care about residual limb, and encourage the patient also to be involved in the society. And it's important to identify the patient's strengths and resource facilitate rehabilitation, and helping the patient to achieve physical mobility, proper positioning, prevent development of hip or joint or knee joint contracture, abduction, external rotation, and the patient with above knee amputation may need to lie prone position to 20 to 30 minutes 3 times per day to avoid contracture. Thank you for your time.
Thank you very much, Ms. Shaima. We can go to Dr. Ali Badra if we have any questions for the last speakers.
Krzysztof Szajewski speaking. I have question general about thrombolysis.
Yes, please go ahead.
What is your experience with thrombolysis? I mean, in practical way, because we use it mostly when complication occurs, and we use RTPA, and we are pretty satisfied with it. If you have a thrombosis, especially below the knee, we, by the direct catheterization of the vessel, use small doses. Usually 10 milligrams vial is sufficient for thrombosis. We give a shot of 2-3 milligrams, and then slowly for 16 hours, usually in large volume of the saline, do thrombolytic therapy. And in most cases, we are satisfied, and we do not have many hemorrhage complications like hemorrhage. More we had general complications like, for example, gastric ulcers and bleeding from gastric ulcers. Of course, it's a contraindication for thrombolysis, but sometimes we don't have a choice. So what's your opinion about it?
Was it for me, the question?
No, just general. Not
maybe
only
I can,
for you, Professor, just for
can
all the
answer,
panelists.
yes. First of all, you are right, the complication rate is not very high. Some of the bleeding occurs on where the sheath is put in and can be managed locally. The dose which you mentioned is, you're correct, we do a bolus lysis, like 2.5, sometimes 3 milligram, depending on how deep the catheter, we put a catheter in, and the catheter is placed below the knee, and then we do a local lysis, which is not very dangerous compared to systemic thrombolysis. And all the literature which I showed is a little bit misleading because it's considering general systemic thrombolysis. But sometimes we see mini thrombotic lesions in the microcirculation, and sometimes you can use a prostaglandin intraarterial to reopen a little bit the vasculature. But if there's thrombotic material, fragmented small material, then it sometimes makes sense to continue the lysis for 6 hours until next morning, or 24 hours maximum. And then we do control angiogram, we see the result, and we can still correct some lesions which are now demasking, which you didn't see in the primary procedure. So this is what we do, let's say, in like 20% of the cases. That's why I was showing you. Some cases, or in ideal cases, maybe my colleagues can answer this. Of course, you can do a complete aspiration, thrombectomy, and then it's finished. But then the patient still needs complete, in our opinion, full anticoagulation.
And additional question, very short. Integrity, because I watched it by our neurovascular team using integrity in cases of thrombosis in the brain, and I started to use it sometimes in peripheral vessels, and it is also nice effect of integrity. Do you have any experience with that?
You mean integrity?
Integrity, antiplatelet, strong antiplatelet drug.
Not yet. Also, there are some other new drugs for thrombolysis, some monoclonal, some other fibrolytic agents. But please send me an email, so I will try it.
Okay.
Mahmoud, you have any comment on Dr. Christoph's question?
No, but I can see there is other question coming from one of our dear audience, Dr. Hani Shinawi. He's asking a very a good question that we do angioplasty for the infrapopliteal for the mostly for the ulcers to heal or for the amputation of the toes to heal. But usually after the heal, usually these vessels re-occlude or can be re-occlude again. So the question is it wise to re-intervene again or not? I will give this question to Martin, if you can answer this question, please.
The re-occlusion, of course, is a problem if it's again combined with acute ischemia, but if it's only combined with, let's say, stable wound and claudication, then it's not necessary to always reopen it again. But in most cases, the patency of these below the knee interventions, they have some limits. I think if you do it in any situation, you will have to calculate that there will be re-occlusions. And this is not specific for acute ischemia. That would be my answer. So the decision is the same as otherwise.
Okay, Dr. Ali Badra I would appreciate much to hear his opinion about this question.
The same way with Martin. If you haven't any trophic changes, you must leave the artery occluded. If you have any problem clinically, you must do a new angioplasty for the vessels.
Okay, that's very good.
One question for you, Dr. Mahmoud. You present a case of trauma.
Yes.
And you have it on the shelf covered stent to use to treat rupture of popliteal artery. You put a uncovered stent, yes?
Yes.
And you plan to use now a covered stent into the uncovered stent or not? You leave your patient like this with leakage?
Well, actually, what happened that we usually use covered stent for such situations, but we did not have the right size for this. So we went for the double supera technique. We put double supera inside each other with some packing of the ulcer, and the leakage were actually minimal in the aneurysm at the end of the procedure. And I'm sure that this within a week or two, usually the whole aneurysm thrombose. So this is actually what happened.
Is it an ulcer or is a rupture of the artery?
Well, actually, this was a bullet. This was a bullet.
Okay. Thank you.
Mm-hmm.
I understand.
Yeah. Maybe this is not the ideal situation, or maybe many people will not approve using two supera stents inside and would prefer to have covered stent, but actually this is what happened, and I guess we had a reasonable result with this.
Okay.
And in case of failure, would you use a cover stent, or would you try to induce thrombosis with thrombin, for instance, or whatever?
No, I would use a covered stent.
Wouldn't you prefer to do
Dr. Ali, I can see Dr. Ahmed Saqr is raising his hands since a long time.
There's one comment about the same case about Dr. Yusa. Wouldn't you prefer to do the surgical bypass for this patient if the double supera stent failed?
The question to Dr. August Yusa.
Oh, sorry. I thought it was a question for Professor Salah. So the question was if I would manage this case surgically?
Yes.
Yeah.
If the supera failed, would you like to?
No, I would probably do the same as Professor Salah. I would just use a cover stent as well.
And for Dr. Salah?
Yes, sure. I would do a covered stent. not if your question is asking whether I do covered stent or a surgical bypass,
Yes.
I will do covered stent.
Okay. And I have a question for Professor Stork. Dr. Stork, you mentioned in the last slides of your presentation that the European Society of Guidelines now is recommending tailoring the acute ischemia according to the surgeon. So you personally, if you have a case of acute on top of chronic ischemia in high-risk patient, what is your strategy? Are you going to operate him surgically, or using the hybrid technique, or using the thrombectomy devices, or using the systemic thrombolysis or pharmacomechanical? What is your strategy?
Well, the answer is, as in my presentation, it depends. Depends on the degree of ischemia, depends on the comorbidities, and I try to show you a few examples if there's too much like renal insufficiency and bleeding history and so on, where you cannot use anti-acute coagulation and lysis, then you might do a surgical thrombectomy. Of course, we always go for endovascular if possible. This is a general rule nowadays. But in some cases also, we have to find out, is there previous surgery or interventions? How complex were they? Sometimes it cannot be reopened by endovascular, and you can judge before, then you might consider bypass in the primary way. But it depends really on the history. If it's really acute ischemia without any other problems before, really acute and first time, then of course you go endovascular. This is a general recommendation.
It seems reasonable to me. So last question for Dr. Yusa. Also, you mentioned in your presentation that you prefer to use the posterior tibial artery vein. Is it available in all the patients in your experience?
Not really, but you can also use the peroneal as well. But one common question is if the anterior tibial is a good vessel to perform a DVA, and the answer is usually not, because the connection of the anterior tibial vein with the forefoot is usually poor. So that's why I recommend to use the posterior tibial.
Nice. Thank you.
Ali, there is a question from Dr. Christoph. Dr. Ali? Dr. Ali? Dr.
Yes, I hear you.
Yes, there is a question from Dr. Christoph. You can. Okay, Dr. Christoph?
Just a short one. We have a different approach in the acute ischemia. I mean, acute ischemia, which must be solved within, I don't know, 2, 3, 4 hours. We usually use open surgery. Our comorbidity approach, we rather, for example, use local anesthesia or such an approach. However, we always open the groin, always expose the femoral artery. We make thrombectomy. However, we always, now we are trying to see using the C-arm what's the point. So our approach is rather surgical still, and the effects are good, I think. I mean, about the lower limb, because in the upper limb we always use surgical approach.
May I make a short comment to that? Of course, it's a good way to do, but you need anesthesia, and if the OR is not free, it can take even longer to start. It can be that in a big hospital like ours, takes 5 hours until the procedure really starts.
We have the same issues, of course. Dr. Aladdin can confirm it. However, we are lucky because one of our surgeons is also anesthesiologist, so we are really lucky. If we have to, he always helps us. So maybe that's why we always do open thrombectomy or embolectomy, whatever.
I have a question to Professor Martin. What do you mean by endovascular management for the whole case of the acute ischemia on the top of the chronic? You mean that you will go for thrombectomy devices and then angioplasty? What do you mean by endovascular, totally, complete endovascular? This is what you mean?
Endovascular means percutaneous with sheath and a aspiration device and necessary thrombus fragmentation.
Aspiration. penumbra or.
Yes, yes. Okay.
Yes. And sometimes what Christoph said, hybrid might make sense in small cut down, and then you have much more options. If you have an exposed vessel, you can take larger sheaths. You have no problems removing the sheaths. You can make a suture because you need anticoagulation afterwards, because after the removal of the sheaths, you need compression of the groin, and this can be counterproductive if you have an ischemic leg and then you put a compression on it. So there's many things to consider what is really the best.
Yes. Okay. Thank you, Professor.
Any more questions?
I have a question regarding the DCB in the infrapopliteal disease. But really, I will make it as a general question, because what I know about the DCB is that you have to decrease the calcium load, that you have to, if you have a multi-vessel disease, how you will use the DCB, how the dose of the paclitaxel will be. If you have a long lesion, what about the safety? What about embolization? We are not afraid from all of this. We can use it safely or not.
I think I will give this question to Dr. Ali Badra.
Yes, I don't use DCB below in below the knee.
Yeah.
A recent Japanese publication show there's no difference in SFA in case of limb salvage between POBA and DCB. I use only DCB in SFA and not in below the knee pathology. And below the knee, I use classic balloon and no stenting.
Okay, but the question of Dr. Ala, do you have limits for the DCP? I mean, if you have long lesion, even in the SFA and iliac, you can use as much DCP as needed, or you have limit for the dose?
My limit is the limit of one balloon. I don't use several balloons to treat SFA with DCB.
One balloon for one lesion.
I use a stent and not only the balloon.
Mm-hmm. Okay. Dr. Ala, this answer your question?
Yes, Ahmed. Yes.
Okay. If we are talking about safety, the systemic review that was published by Katsanos didn't mention the critical limb ischemia or infrapopliteal disease. It is not included in the study, so he have no issue about the mortality using the DCB in below the knee intervention. He was talking about the claudicant patient and using in the SFA and popliteal artery. Secondly, as Professor Badra said, we have recent studies suggesting that limb salvage rate and decreasing total revascularization in below the knee arteries is recommended with DCB. Some studies as Acute from the Japanese guys showing a good result about the DCB using in below the knee. So I think still it's a debatable area, but if you have, as Professor Stork said, if you have something to beef and crack the artery before using the DCB in the below the knee, especially in the upper two thirds, and using the DCB, it will give you a higher patency rate than usual, than 30 to 50% we have for now.
Thank you, Ahmed, for your comment. But my question is regarding the multivessel disease in the below knee. If you have 3 lesions, for example, if you have anterior tibial and the posterior tibial and the peroneal artery, and you will both nearly, you have lesions nearly reach to 20 centimeters. So what you will do?
That will bring us back to how you are putting your strategy to treat the below the knee vessels. Are you going to multi-vessel revascularization or single vessel revascularization? Yes. Which vessel you are using? Which vessel you are using as a target artery path? And this will lead you finally to use one DCB in the target artery that will have a linear flow to the wound area.
But we are talking about the limits.
I think yes. I agree with Ahmed. You can use this DCB for the main artery.
The main target
main lesion.
Yes,
for the main lesions.
Yes.
I think Dr. Christophe need to comment. Have a comment.
Final comment from Dr.
My
Christophe.
My comment is that I have noticed, but I have really cannot say it is supported in the literature, but the DCB action is anti-inflammatory mainly. So I have noticed that in diabetic patients, it works very well. I mean, it's not measurable somehow. However, if the patient is diabetic, and for example, we have had some patient directed to us from rheumatology department who have some inflammatory diseases of the vessels and diabetes and of course arteriosclerosis, the effect was outstanding. So I think that I don't know if any kind of literature support for that, but I have noticed that that kind of inflammatory arteriosclerotic lesions are more curable with drug-eluting balloons. However, this is a final stage. The first thing you have to cross, then you have to prepare the vessel, and finally you use DCB. This is for me normal strategy. It's not, the gold standard or any kind of holy grail for below the knee lesions. However, in inflammatory cases and in diabetic patients, it's really effective, I would say. What's your opinion?
I agree. I think the situation depends on first the strategy of treatment of the below knee lesions and which artery, the target artery path which you'd like to treat. And then when we reach to the stage after crossing, after preparation of the vessel, the stages here, if you would like to put a DCB or PUPA, it depends, of course. But I think I nearly agree with you. Thank you.
Thank you.
Thank you very much. I guess we reached the end of the webinar. I was very happy and very impressed of all the talks. I would like personally to thank Dr. Christoph, Dr. Mark Stork, Dr. Yusa, and of course Marco Manzi and Dr. Ahmed Saqr, Ms. Shayma for the talk. Of course, Dr. Ahmed Effendi is on the top of the list. I'd like to thank also Dr. Ali Badra and Dr. Ala for being panelists and moderating this session. I would like to thank also Mr. Shobit and the Saudi German Hospital for hosting this webinar, and hopefully we can meet again in other webinars. Thank you very much for everybody, and sorry to take you in the weekend. Have a nice weekend, or what's the left of the weekend.
Thank you very much, Dr. Mahmoud, and thank you for all the elegant presenters. Thank you.
Thank you very much. Thank you very much.
Thank you. Thank you very much. It was a pleasure.
Thank you.